Hi everyone, welcome. Tonight we have another specialty VMR. This time it's oncology, not hematology, with two incredible guests, Dr. Sam and Dr. Meera. Dr. Sam Brondfield, he's an assistant clinical professor at Department of Medicine and Division of Hematology at UCSF. Thanks so much for coming, Sam.
Happy to be here. Thanks for having me.
We also have Dr. Meera Ragavan. She's a Hemonc Fellow at UCSF. Thanks so much for coming, Meera.
Yeah, it's great to be here.
Before diving into the session, I'd love if Meera and Sam could talk a little bit about their experiences outside of medicine. What do they do for fun? Any current projects that they are working on? So could you please go ahead, Meera?
Yeah, sure. So outside of medicine, I'm pretty much doing whatever my toddler is doing these days. So I have a just over two-year-old daughter. And these days, let's see, it's like pretty much like being outside, blowing bubbles and sticker books, which actually are super therapeutic activities for adults, as I realized. So that is my life outside of work, and it's a fun one. And then project-wise, my research interests are around financial toxicity of cancer care. So I study sort of the financial implications of a cancer diagnosis, both at sort of the policy level, like thinking about the impact of insurance and payer on health outcomes, but also at the patient-facing level. So thinking through what are ways we can mitigate the high cost of cancer care for our patients, connect them to resources and the like.
Oh, this is incredible. Thanks so much for doing it. I just wanted to ask you, because we have so many medical students from across the globe here, what made you interested in going to Hemonc?
Yeah, that's a great question. I think the things that drove me to oncology are really the things that drove me to medicine. It's a super patient-oriented, humanistic field where you're making kind of like high stakes clinical decisions and often very nuanced clinical decisions. Really have to think systematically. And it involves a lot of shared decision making with patients. And those are sort of all the reasons that I got into medicine. Like I was interested in the complexity, the problem solving aspects of medicine, and sort of the humanistic aspects of medicine as well. And yeah, it became really clear to me very early on in medical school, and then, kind of emphasized in residency, that the field of oncology just really brings all those things together. So it's a great field, a really rewarding one. Yeah.
Oh, thank you. Sam, what about you? Could you please talk a little bit about your activities outside of medicine, any current projects, and what drove you into Hemonc?
Definitely. Hi, everybody. So outside of medicine, my main hobby is singing, and I'm in the gay men's chorus in San Francisco, and we put on shows pretty often. So that takes a lot of time and is something that I don't think I would have had time for during training, but started doing as soon as I finished. And then I spend time with my partner who's in medicine as well. So we both have pretty matched and busy schedules, which is nice. And then time with friends and family. So that's most of my life outside of work. And my work-life balance is a lot better now than it was in training too. So that's nice to know. And then my work, my research is mainly in medical education. So I do education research, and I help run a couple of medical school courses too.
Mm-hmm. And what drove you into Hemonc?
I think for me, it was the combination of the really fascinating science in Hemonc that, in oncology, there's new practice changing stuff that happens every year and even more frequently than annually. So it's a really interesting and fast-paced field. And then cross that with what Meera was talking about how humanistic and emotional the field is. I just felt like that combination, you can find that combination in other fields, but in oncology, it's just like exactly what we're all about. So that's what I love about it and why I went into it.
Yeah, I feel like the humanistic aspects of oncology is really strong in the field. Thank you all so much for coming. We also have Mukund. He'll be helping with Scribe. Maybe you can talk a little bit about yourself, Mukund, as well.
Sure. Hello, everybody. I'm Mukund. I'm a second-year medical student at UCSF. So a nice overlap. I get emails from Dr. Brondfield, so it's cool to see him here. Outside of medicine, my big hobby is astronomy and astrophotography. So you all know that I'm interested in taking pictures of the stars.
Yeah, we want to see those pictures one day. I'll pass the mic now to Madalena, who will be presenting the case.
Hey everyone, my name is Madalena. I'm really excited to be here and learn from Sam and Meera. I'm a medical student in New York at Hofstra, Zucker School of Medicine, and I'm taking a year off, so I'm currently in San Francisco. And outside of medicine, I have a little bit more time this year, so I have really been enjoying going on hikes along kind of the shoreline in San Francisco. I really love to do that.
Yeah, my time in San Francisco was incredible. I just had problems with the heels, you know, so many heels.
Yeah.
You have to have such strong knees to walk in San Francisco. Now pass the mic to Shema. She'll be helping us today with scribing.
Hello everyone, I'm Shema and I'm a 50 medical student from Germany, and outside of medicine, instead of taking pictures of stars, because I'm not that good at it like Mukund, I like to take pictures of people. Yeah.
Much closer, much easier to take the picture. Thank you so much, everyone, for coming and for helping. So maybe, Shema, if you can share the screen, we can start.
Awesome. Okay, so Meera and Sam, so I'm going to present the case in about 4 aliquots before the final diagnosis. And let me just go ahead and pull up the case. Okay, so the chief concern is back pain, and I'll give you a little bit of the HPI as well. So this is a 77-year-old male presenting with a 2-month history of progressively worsening back pain. So he states that the back pain is associated with some stiffness that improves within 10 to 15 minutes after waking up in the morning. He also says that neither rest nor activity improves this pain. So I'll just pause there and get your initial thoughts before giving you some more of the HPI.
Yeah, so I can start. So, you know, whenever I think back pain, I honestly go back to medical school a little bit and think about just like red flag symptoms. And the way I usually approach clinical reasoning is I'm always sort of thinking about like things that I don't want to miss first, and making sure I've thought through like any diagnostics that I want to pursue to make sure I'm not missing anything that's, you know, life-threatening or dangerous. And so, you know, red flag symptoms with back pain, I think progressive nature of it can definitely, you know, if it's getting worse, especially, you know, with like conservative management, if it's getting worse over time, you know, that's a red flag. I was asked about like fevers, night sweats, sort of other systemic symptoms that might clue me into malignancy. Of course, we're in the field of oncology, so we're always thinking malignancy. So those are other things I would ask about, weight loss. And then I also ask, you know, think about neurologic symptoms. So, you know, weakness, numbness, tingling in the legs, which would clue me into like, is this something, you know, is this something that's kind of infiltrative that could be causing neurologic, you know, compromise, cord compression, that kind of thing. So I think that's where I would start asking some of those questions.
Oh, incredible thoughts, Meera. So Sam, putting on your onc hat, what would you think in terms of history when you see a patient with back pain, like, oh, this could be malignancy?
Yeah, I don't have a lot more to add on top of what Meera already said. And I really like the focus on red flag symptoms that she brought up. I'll just say that back pain, especially lower back pain, is very common in especially older people. And there are very benign causes of it, muscular causes, arthritis. When I hear about back pain it doesn't get better with rest or even better with movement, doesn't sound inflammatory or muscular, and the fact that it's progressive and kind of always there, that's already a little concerning to me, that there could be some process that's constantly there and evolving. So that makes me, as an oncologist, worry a bit more about malignancy. And then to your question, Rafa, thinking about like, if this is cancer, what am I thinking about? There's a lot of possibilities. The spine is a common place for metastases from a number of types of cancers. In an older person with a prostate cancer would probably be epidemiologically the most common one to go to the spine. Lung cancer, another epidemiologically common solid tumor, often metastasizes to bone. Colon cancer can also metastasize to bone. So those would be the three most common in somebody without breasts. Breast cancer is also a common one that can go to bone. Multiple myeloma is also a kind of non-solid tumor, but the spine is a frequent place to find that. So there's already just a list of cancers that I'm thinking about. There are primary bone tumors, sarcomas. Those are quite rare and often happen in young or middle-aged people. But yeah, if all in all, the spine is a common spot for metastatic spread and then multiple myeloma. So those are some initial oncologic thoughts.
Incredible thought. Thank you. Please go ahead, Madalena.
Amazing. Okay. I loved kind of the red flags for back pain and the different types of cancers that metastasize to bone. So a lot of learning just from the first aliquot. So I'll give you some more of the HPI. So the patient says that the back pain, in addition to the back pain, this pain seems to be radiating to the left leg. He describes a numbness and tingling sensation on the left lateral leg that started about 2 to 3 weeks ago. He does not report any weakness of those legs. Review of systems is negative for any changes in his urinary frequency or any noticeable blood in his urine. He also reports no other joint pain, and the rest of the review of systems is unremarkable. In terms of the past medical history, the only past medical history we know of is that he reports an elevated PSA to 8.8 6 months ago. He says that he has not been evaluated by urology due to his preference. And we unfortunately do not know any information about his social history, no notable family history, and he does not take any medications. So I'll pause there to see if you have any thoughts before we jump to the physical exam and the vitals.
Sure. I think Meera's computer cut out temporarily, but she's going to be back with us. So I'm happy to chat about this part. And just to check in, Rafa, did you want me to comment or did you want to take questions from the group first?
No, you can comment first. If there is any question, if there are any questions, I can ask you then.
Okay.
Thank you.
Great. So based on the new information, so we have what sounds like maybe neurologic consequences of a spinal issue, potentially with the pain radiating to the left leg and numbness and tingling. That could certainly coincide with a spinal lesion, either a radicular lesion that hits the nerve root coming out of the spine, or potentially a cord issue. One is less concerning than the other. So there are lesions that can hit the nerve root that don't cause cord compression, but can certainly cause this kind of syndrome of radiation down the leg and numbness and tingling. And then there's all the way to cord compression, which is an acutely concerning syndrome. So we don't know yet what boat we're in. There are also peripheral neuropathies that might be unrelated to structural lesions, but with the back pain plus this syndrome, it sounds worrisome for something going on in the spine. I'm glad that there were a review of systems commenting on urinary changes. So it's always thinking about the bowel and bladder as late signs, as well as kind of saddle anesthesia of cord compression. So we'd always want to ask in a patient like this about bowel and bladder symptoms in addition to neurologic symptoms, and asking about gait to see if whatever's happening is affecting this person's ability to ambulate. The elevated PSA is concerning, especially in the context of this being an older person, presumably with a prostate, who now is coming in with what sound like spine symptoms, knowing that epidemiologically prostate cancer is a common one to metastasize to the spine. Any PSA greater than 4 is concerning for prostate cancer, though there's a sensitivity and specificity at multiple levels of PSA. So a PSA of 8.8 is not necessarily malignancy. It could be BPH or other benign prostatic conditions, but that level combined with the syndrome is concerning for prostate cancer. So those are my thoughts so far on what we're seeing, and happy to answer any questions too.
And what would you be most interested in the physical exam? Any type of maneuvers or anything else that you'll be looking for?
Yeah, that is a great question from the generalist perspective, and generalists are the people who are often working up syndromes like this, either in the inpatient or outpatient setting. And I will say generalists are amazing at physical exam. Oncologists we try to be good at it. We so often end up relying on our imaging to tell us what's going on in a case like this. But for sure, a physical exam should be done and should look again for signs, especially acutely, of cord compression, looking for saddle anesthesia, looking for rectal tone, looking for signs of cord in terms of Babinski or other motor neuron signs. So definitely a thorough neurologic exam would be the most essential thing to do here. And then I would want some imaging pretty quickly to rule out cord compression.
Awesome.
Someone,
go ahead, Rafa.
Someone asked, could you give us an overview about osteoblastic versus osteolytic metastasis? I don't know if it's something that you address on your JLA activity.
Yeah, no problem. And I see that Dr. Ragavan's rejoined us, so I want to bump to her. And I don't know, Meera, how much of that discussion you just heard. There's not been too much more added, just what you see on the screen around the neurologic syndrome of the left leg, no bladder changes, and then an elevated PSA.
Yeah, just catching up. Sorry, my Zoom cut out. Perfect timing. But osteoblastic versus osteolytic metastases. So I usually think about these as like, and Sam, you can jump in as well, but as like osteolytic, I think of more as destructive of bone. Osteoblastic is sort of more like replacing of bone. And there are some classic tumors that we think of that are associated with both. So osteolytic lesions, I think more of like myeloma. I think of lung cancer when it goes to the bone. For prostate cancer, that's the one that I often think of like more of an osteoblastic appearance radiographically. And Sam may have others on his mind as well.
No, literally nothing to add. That's exactly what I was going to say.
And some can be mixed, right? Osteoblastic or like in the middle of it. I don't know. We see like the circles, osteoblastic, osteolytic, some cancers are just in the middle of it.
That's a great point, Rafa, that yes, I've seen lots of cases of metastatic prostate cancer with mixed osteoblastic and osteolytic lesions. So it's not quite as discrete as Meera and I were describing, but for learning purposes, I totally agree with those associations that generally prostate cancer is associated with osteoblastic lesions, and many other cancers like breast cancer, lung cancer are more commonly associated with osteolytic.
Oh, thank you. So please, Marilyn, go ahead.
Okay, great. So jumping to the physical exam. So the vitals overall the patient was stable and the vitals were all within normal limits. For the exam, cardiovascular, pulm, abdominal were also all unremarkable in this patient. Jumping to the neuro exam. So cranial nerves 2 through 12 were intact. In terms of strength, strength was 5 out of 5 in the upper and lower extremities bilaterally. In terms of reflexes, the biceps were 2+ bilaterally, patellar 1+ on the left and 2+ on the right. That's all the information we have with the neuro exam. And then a prostate exam was performed, which showed bilateral symmetrical non-nodular enlargement. And I will pause there to get your thoughts.
Yeah, so I would say, overall a pretty unremarkable exam. I'm definitely reassured by the neuro exam, that he's got full strength in his lower extremities. If he had weakness, that would really be giving me some urgency to really like get an MRI sooner rather than later to make sure we're not dealing with cord compression. But, the 1+ patellar versus 2+ on the right, I don't know. I don't test a lot of reflexes these days, but I don't make too much of that yet. Although, if he was having a lot of symptoms, that if he's having a lot of like numbness, weakness, like subjective weakness, I might do a more thorough neuro exam, maybe check for sacral anesthesia, things like that, just to be more thorough. But I think overall it's a pretty unremarkable exam. And then the prostate enlargement, He's 77. And so most men of that age will have an enlarged prostate. I'm reassured the fact that he doesn't have any obvious nodules. And I think the prostate exam is often one that we don't necessarily have even in this setting. I think this is a pretty thorough exam that's been done, but nothing that's really sticking out to me as far as red flags.
Yeah, I agree with Meera. And if this were like a board's question, I would think it was like obviously driving at metastatic prostate cancer with the elevated PSA, the abnormally enlarged prostate, and now the spine, the concern for the spine and the neurologic findings. And it's important to keep our differential broad. And as Meera said, the enlarged prostate might be a benign process. The PSA is elevated, but not incredibly high. And the neurologic exam is not terrible compared to what we might expect from the symptoms the patient's coming in with. So I think it's important to keep a broad differential here, though metastatic prostate cancer is certainly high on it.
Yeah, I love that thought. Like we shouldn't narrowing our diagnosis right now. I'm seeing you two talking a lot about chord compression and the urgency that comes with it. Could you please talk a little bit about that? Like we have so many medical students here. So maybe just in a brief overview, what is chord compression and why you worry about that?
Yeah, so chord compression is, when the nerves in the spinal cord are compressed, most commonly, especially in our field, from a space-occupying tumor in the spine. But you can also get chord compression from like severe injury or herniated disc, other things like that. And the urgency of it is when all those nerves are damaged, especially by something that's space occupying. There's a risk of permanent damage if it's not managed quickly. And there's a lot of swelling that can form around, compressed nerves as well, and that can kind of further compress them. And so the permanent long-term neurologic damage is really what we get concerned about. And so for chord compression, generally if our suspicion is high, which, I agree in this case, even though he has a normal neural exam, I think we still would be jumping to imaging pretty quickly, just given the symptoms and the elevated PSA. The thing that you want to get done really quickly is an MRI. And I think an important teaching point is, a CT spine is really not the imaging study of choice. MRI is a lot more sensitive to look at the nerves around the spine. If you can't get an MRI for whatever reason, it's reasonable to get a CT just to start. Sometimes it can show you sort of gross changes or can show you, bad chord compression, but the MRI is really the study of choice. And then, I think our approach to chord compression is really getting neurosurgery involved very quickly, as soon as you have an index of suspicion for it, as well as starting steroids quickly, because as I mentioned, a lot of the edema that can actually drive part of the problem, you can mitigate quickly with starting high-dose steroids. And so it's never wrong to start high-dose steroids in somebody who have a high index of suspicion, might have chord compression, because again, you're really trying to avoid, long-term neurologic deficits. And I'll let Sam jump in with any other thoughts.
No, that was a great overview. Nothing to add.
I just have one question. Primary bone tumors and metastatic tumors can lead to chord compression. If so, which one is more common?
Yeah, I would say we probably see it more commonly in the setting of metastatic tumors, although primary bone tumor is the one that jumps to mind in particular is multiple myeloma, which can involve the spine a lot, theoretically could cause chord compression. I think, myeloma is more sort of bone marrow replacement. And so in order to get chord compression, often you need to have like a bulky bone tumor that's really kind of like impinging on those nerves. And so I think we see it a lot more commonly with solid tumors, but I think you can see it, with hematologic malignancies as well.
Yeah, I think a lot of that's also epidemiology, that some of the solid tumors we've talked about are just more common than myeloma. So I agree with Meera. Almost all the cases of chord compression I see are due to metastatic solid tumors, most commonly prostate cancer, breast cancer, sometimes lung cancer. But in the hematology camp, myeloma can definitely do it. And interestingly, the treatment of chord compression is different depending on what type of cancer you're dealing with, and also the severity of the cord compression syndrome. Most of the solid tumors, the main treatment is surgery. But for hematologic cancers, myeloma and occasional lymphoma, those are very radiation sensitive. So radiation is typically done instead of a major surgery in cases like that.
Oh, thank you so much. Love the teaching point. Please go next, Madalena.
Awesome. And I actually had a quick question just based off of that last point, if that's all right, before I jump in to the next data. So you've talked about some of the cancers like the breast, the prostate, that have a higher likelihood of metastasizing to the spine compared to other cancers. And I was just wondering, like, what kind of the why behind that? Like, what is it about maybe how those cancers spread that make it more likely to go to the spine?
I'm gonna let Sam take that one. I think the short answer is we don't really know. But
okay, yeah, I was just curious.
Yeah, and I agree with Meera's short answer that I think it's complicated, and that in general, we probably can't provide a terrific explanation for that. I can comment on a couple principles. Number one, again, is just epidemiology, that we most often see metastatic cancers from cancers that are common. But I think more to your point, it may have something to do with tumor microenvironment and the kind of microenvironment that different tissues set up to be either hospitable or inhospitable for certain cancer types to spread to them. For example, lung cancers most often metastasize to the other lung. And that's probably because lung tissue is by nature hospitable to lung cancer. So similar explanations have been posited for the rationale behind different metastatic spread of different tumors. Beyond that, I really don't have a great explanation as to why, but great question.
Okay, awesome. So I will jump into the last bit of information here. So in terms of some labs, so a CBC and a CMP was obtained without any abnormalities. An ESR was 25. A CRP was 5, and a PSA was 12. An X-ray of the lumbar spine was obtained, which showed bridging syndesmophytes and degenerative changes at L4 to L5 and L5 to S1. And the last information here I have is the MRI. I can give you some of that information, or I wanted to pause here to see if you wanted to make any comments on just the information I gave you.
yeah, so I think, again, I don't think this information changes our differential too much with metastatic. I think it, I think it kind of emphasizes or maybe reinforces, metastatic prostate cancer that's at the top of our differential, just with that rising PSA. PSA of 12. I think is definitely heading into the range of, okay, this seems pretty likely that this is going to be prostate cancer. An elevated PSA of 5 to 6 that's been stable over a few years, while 4 is the upper limit of normal on a lot of our labs. So there are cases where that can be related to BPH and may not be prostate cancer related, but with a clearly uptrending PSA that's like reaching this range in this time period of 6 months, I think this is prostate cancer until proven otherwise. And I think maybe the only other thing to note, good that all the other labs are normal. One thing I'd maybe be looking at a little bit is the ALK phos on the LFTs. That's a nice marker of, bone breakdown. And we often see it elevated in patients who have osseous mets. So that's just something I would probably peek at while I'm looking through labs. But yeah,
I have. Oh, sorry, Meera, go ahead.
Oh, no, that was it.
The only other lab I was interested in would be, maybe they just weren't provided yet. I was interested in the chemistries and specifically the ALK phos to know something about bone involvement. And I think going straight for MRI imaging is honestly what oncologists probably would want anyway. But just thinking through like stepwise exam and then labs and then imaging, there could be some clues here. And again, just to reiterate, I agree with Meera, still metastatic prostate cancer is very high on the differential, though in a 77-year-old, an enlarged prostate and, osteoporosis or osteoarthritis with these degenerative changes on X-ray, there are potentially benign findings for potentially everything that this person's coming in with. But as oncologists, I would be concerned about prostate cancer and will be curious what the imaging and the workup shows.
Before moving to the imaging, Sam and Meera, I wonder what is your input about the PSA screening? Because I know that some people feel like it shouldn't be ordered. Some people say it should. Maybe you could comment on that a little bit.
Yeah, it's a really tough question. And I think this is one of these areas of like true shared decision making, maybe with some nuances and some caveats. So in general, for the audience, the like screening guideline recommendations for using a PSA to screen for prostate cancer have, I think, evolved a good amount, over the last decade or so. It used to be, I think, more part of routine screening. Now it's kind of fallen out of favor for routine screening, although it is an area of shared decision making, with the patient. The reason that it's controversial is because, an elevated PSA doesn't necessarily mean you have prostate cancer. Like we've talked about, an elevated PSA can be, due to a benign condition, BPH, which is very common in older men. The other part of it is that prostate cancer is one of those types of cancers that is quite indolent. And there's some statistic, I don't remember what percentage, but there's some statistic of like a certain percentage of men at the time of autopsy, prostate cancer will just be found incidentally, which, is sort of this idea of prostate cancer is one that you may find that may never be clinically significant in certain cases. And so do you go chasing a PSA in an older man that, if he's found to have prostate cancer, especially if it's a favorable kind of low-grade prostate cancer, is it really going to change his overall survival, and overall clinical outcomes? So that's another piece of it. And I think, the way I talk about it with patients is, I incorporate things like family history, the patient's own personal history with prostate cancer. Sometimes if they saw a friend go through it, that sort of is, personal reason why they may want to know sooner. Some patients prefer not to know, they're kind of like a less is more approach, and they don't want to go through the potential pathway of finding a positive PSA, where if the PSA is positive and then rising, you might eventually get an MRI, but what if the MRI is kind of indeterminate? And then you're left with maybe this anxiety of, is this malignancy? Is this not? So I think it's, there's sort of a pathway you go down when you start screening. And I just try to be honest with patients about what that pathway may look like and the pros and cons, and then make a decision together about what makes sense for them.
All right, fantastic. Oh, go ahead,
Fantastic.
Rafa.
No, I just wanted to see if Sam has anything else to say. I loved your thoughts, Meera. Thank you for sharing.
Yeah, no, I have basically nothing to add. I actually have given a talk recently on cancer screening, and PSA screening among the common types of cancer screening is definitely the most controversial. It has been shown to reduce death from prostate cancer, but the statistics are much less impressive compared to the reduction in death that you get from mammograms, from CTs for lung cancer, and for colonoscopies and other forms of colon cancer screening. So it's controversial. The number of people needed to screen to be able to prevent one death in prostate cancer is pretty high. And chances are the cancer that is found by prostate cancer screening might never cause harm to the patient. So those are the principles that make it complicated. And the current status, as Meera said, is shared decision making with patients because of all that uncertainty.
Incredible, thank you. Please go ahead, Madalena.
Okay, great. So I'll give you the MRI of the lumbar spine here, and then that'll be the last bit of information before I give you the case resolution. So the MRI of the lumbar spine, the read was likely metastatic lesion in the lateral aspect of the L4 vertebral body. This contributes to impingement of the descending left L5 nerve root. Numerous osseous metastases, including the right iliac bone, right femoral head, and lumbar spine at L3 through L5. There was also a 4.4 centimeter left renal upper pole mass. And I will pause there before sharing the case resolution.
All right, so I think the MRI is showing us, I think, what we had feared we might see, which is clearly, evidence of osseous metastatic disease in the spine. It seemed like from the read that there isn't like true cord signal, so edema around the cord, spinal cord itself, but there is some nerve impingement, I think is what I heard. So it doesn't sound like this is cord compression per se, but that there may be some impingement of one of the nerves, that could be contributing to some of his symptoms. And then I think maybe the thing that we weren't expecting to find on this is he has a 4.4 centimeter left renal upper pole mass, which, I would say definitely needs to be better characterized with a CT abdomen. We've been talking about prostate cancer, but renal cell carcinoma is one of those that we find incidentally pretty frequently. Renal cell carcinoma can be indolent, these tumors can sit on the kidneys for years, and we often find them only when, we're working up for other things. So could this be a primary renal cell carcinoma that then metastasized to the spine? And then, kind of incidentally, we also have this rising PSA, like he could definitely have multiple things going on. And so, this is definitely leading to, a biopsy of something to try to get a diagnosis. Yeah, I think that's, so I think systemic imaging, would be next, CT chest, abdomen, pelvis, really to get a sense of the burden of disease. And then, tissue biopsy would be next.
I totally agree. And as with the imaging part in oncology, the biopsy will be kind of what we really look to determine what's going on and what the treatment plan will be. But it is definitely intellectually interesting to think about at this juncture, what's the most likely cancer to be causing these metastatic lesions. And my vote at this juncture would still be for prostate cancer. The reason is, number one, epidemiologically, it's more common than renal cell carcinoma. Number two, it's really common to metastasize to bone. That's the most common site of metastasis for prostate cancer. And number three, just knowing something about renal cell carcinoma. So when you see a 4.4 centimeter renal cell carcinoma, or what could be, to make that diagnosis, we would need, as Meera said, a dedicated scan to tell us whether it has radiologic features of renal cell carcinoma. But presuming that it might be, renal cell carcinoma does metastasize to bone. And the rate of metastasis is directly proportional to the size of the primary tumor. And 4.4 centimeters, surprisingly for RCC, is not that big. In fact, that would still be considered very early stage renal cell carcinoma up until you hit about a 7 centimeter lesion. And renal cell carcinomas can metastasize when they're this small, but it's pretty unusual. So all of that to say, if I were guessing, I would say this is probably metastatic prostate cancer with an incidentally found renal cell carcinoma. But we'll see what the biopsy shows, because again, there's atypical scenarios, and we wouldn't move forward with the treatment plan before we have tissue confirmation of which scenario we're dealing with here.
Before we move on to the diagnosis, Madalena, maybe Sam or Meera could talk a little bit about, because we talked a lot about the prostate cancer, maybe we could talk about renal cell carcinoma, touch briefly on the epidemiology, which type of population are more prone to develop this type of cancer, what we can expect in laboratory diagnostic testing.
Yeah, I'll be brief, and then I'll punt to Sam, who I think could probably give a more detailed explanation on RCC. But I think epidemiologically, so there's a couple different types of RCC. There are, like, more rarely some hereditary RCC syndromes, of which there's a bunch that can run in families, or it could be hereditary conditions. But the vast majority of RCC, I'm not aware of any like specific exposures or risk factors necessarily, but I'll let Sam weigh in. And I think, as Sam mentioned, like a lot of RCC we do catch early. These tumors do have to get pretty big before they metastasize. And so a lot of times RCC, early stage RCC is curable. A lot of patients actually can just be surveilled depending on the size of the tumor. But then, if the tumors are growing, then some patients will go for ablation or surgery. And then in the metastatic setting, RCC is one of the tumors that responds really well to immunotherapy. So I'll just kind of highlight that, there's a good proportion of patients with RCC that have a really dramatic response to immunotherapy. Immunotherapy doesn't, it's kind of our new kid on the block for cancer treatment. It doesn't work in every tumor type, but RCC is one of sort of the classic tumors that it works well in. And then I'll punt to Sam for additional teaching points.
Yeah, really not much to add. It most commonly pops up in middle-aged and older people. And then I think the key for kind of generalist and diagnostic workup is that this is a cancer that can be typically readily identified radiologically and often doesn't even require a biopsy for diagnosis. So either a renal protocol CT or an MRI are usually sufficient for diagnosis. So in this case, where we have metastatic lesions, we'll need to biopsy a metastasis to confirm what cancer is metastatic. But one way or another, getting a renal protocol CT or an MRI is probably going to be the best way to characterize this RCC. And once we figure out what the metastases are from, if they're from prostate cancer, we may end up leaving the RCC alone potentially. Or if it's metastatic RCC, we'll need to treat that.
Thank you, Sam. Thank you, Meera. Please go ahead, Madalena.
Okay, I love how both of you are kind of going back and forth about which one was the incidental finding, the PSA or the renal mass, and then, talking about which epidemiologically, which one was more common. That's just really wonderful teaching. So in terms of the case resolution that I have here, so a biopsy of a renal mass was done, which confirmed renal cell carcinoma. However, due to the patient's age and goals of care, he actually declined treatment and elected for palliative care. So that's actually all the information I have on the case here, but I just really appreciate both of your kind of amazing teaching, and both on prostate cancer and renal cell carcinoma. So just thank you so much.
Oh, thank you, Meera. Thank you, Sam. We have a question on the chat. Would you expect macroscopic hematuria rather in bladder cancer or cancer of the ureters or also RCC?
Yeah, so you can get macroscopic hematuria with any of those cancers. I think that I think it's most commonly seen in bladder cancer. It's sort of closest to in the ureteral system. And so, but you can definitely get macroscopic hematuria or even microscopic hematuria with RCC as well, but not seeing it doesn't rule out the presence of RCC for sure.
I wonder if Meera may have a similar comment on the cases I'm thinking in my head. I want to let Meera kind of maybe discuss the workup here. And it was interesting the way things proceeded in this case. So I'm curious to hear her thoughts.
Yeah, I think we're probably both a little bit surprised at the site of tissue biopsy. And I think this is a common consult question we get on the inpatient service. Not uncommon that we may see multiple sort of findings that may not all correlate to one process, and sort of picking a biopsy site, I would say, is something that we're pretty thoughtful about. I think to Sam, as Sam mentioned, in this case, I think our suspicion is higher that this would have been prostate cancer metastatic to bone rather than RCC metastatic to bone. And so, I think my next step would have been to get the full CT chest, abdomen, and pelvis, and then figure out what a good biopsy site might be. If bone was the only site of, of metastasis, I would go for the bone biopsy. One thing just to note as a teaching point is that bone biopsies can often be a little bit more challenging to interpret. Bone is kind of hard material to parse through for a pathologist, and so it doesn't always yield an amazing biopsy result. It can be hard to send for molecular testing and additional testing that we may want on tumors. But if it's the only site of disease, I would really want to know what was in bone, what was the metastatic process, was it prostate or renal? And so it's not surprising maybe that the renal mass was biopsied in RCC, but that still doesn't tell us what the metastatic process was. I guess the last thing I'll say is that if this was prostate cancer metastatic to bone, our treatment options for prostate cancer, first line treatment is hormone therapy. So sort of anti-androgenic therapy, or what we call androgen deprivation therapy, or ADT. And we can actually get treatment started really quickly for patients. We have a injection, Degarelix or Lupron, both injections that can be given and started in the hospital very quickly, can actually alleviate symptoms. So if this was prostate cancer metastatic to bone, he was having symptoms because of the bony involvement, treatment can actually palliate symptoms and help patients feel better, even in an older patient. So I think in this case, this is a patient where I may have, would have probably pursued the bone biopsy or another biopsy site, depending on what the CT showed, and then really talked about the potential benefits of treatment. And yeah, curious to hear Sam's thoughts as well.
Yeah, I definitely agree with Meera. I think the most likely scenario in this case is that the kidney lesion is the only site of RCC. And having biopsied that, we still are in a place where we don't know for sure whether that's true or whether there is truly metastatic RCC. But I think Meera and I were probably both thinking that the kidney lesion was highly likely to be RCC, and still suspecting the rest of it could be prostate cancer. Just interestingly, care should absolutely always be in line with goals of care, and anyone with metastatic cancer, if they're not into treatment, it's totally reasonable if they would prefer to do hospice. Interestingly, the two metastatic cancers that were being considered in this case both have treatments in the first line that are not sort of very toxic chemotherapies. As Meera said, metastatic prostate cancer, the first line treatment is hormone therapy, which certainly has side effects, and those side effects can be severe, but don't come with some of the classic kind of side effects of cytotoxic chemotherapy that many people find unbearable. Metastatic renal cell carcinoma, the first line therapy is now typically immunotherapy, plus or minus a combination with targeted therapy, which again have their own side effects, but many people have a fairly smooth course with immunotherapy and or targeted therapy. And the prognosis of these two metastatic cancers, metastatic hormone-sensitive prostate cancer and metastatic RCC, are actually quite good compared to other metastatic tumors where the prognosis is very short, even with therapy. So metastatic hormone-sensitive prostate cancer, if someone starts on hormone therapy, the median survival is in the range of 4 to 5 years, which still obviously is not great compared to someone who could live a lot longer than that, but is quite a bit better than some other solid tumors where metastatic disease portends a prognosis of a year or less in many cases. And same with RCC. Metastatic RCC immunotherapy has totally revolutionized the prognosis of metastatic RCC. And now the average survival is about 5 years or longer. So these are two of the sort of better prognosis cancers in the metastatic setting. Still, obviously totally reasonable for someone to opt against therapy, but that information can just be helpful when counseling a patient about where to go next.
When you say immunotherapy, do you mean like it's a therapy that you can activate your immune system against the cancer? How does that work?
Meera can totally take that one.
Yeah, I'll take this one. So immunotherapy, as I mentioned, kind of our like newer kid on the block, although it's not as new anymore. It's been around for a while now. But just as you said, Rafa, it's an IV therapy. There are a few different flavors of it, that it effectively acts by activating your immune system to recognize the cancer as foreign. Our immune system should already be recognizing cancer as something that doesn't belong there. That's kind of the role of our immune system, is to identify when bacteria or virus or something foreign is in the body. But cancer is pretty sneaky. A lot of cancer cells have developed mechanisms to actually shut down our immune system. So our immune system doesn't have that ability anymore to see the cancer as foreign and really go after it and try to get rid of it. And so immunotherapy works by basically, shutting down the cancer's ability to shut down your immune system, therefore reactivating your immune system, against the cancer. And it is used in a lot of different types of cancer now. As we mentioned, renal cell carcinoma, melanoma is another classic one that immunotherapy has had great outcomes in. We use it in lung cancer. We use it in some types of GI cancer. It's used really across many different types of cancer now.
Just incredible. Just like you both were mentioning in the beginning, like oncology is always evolving, right? Like so many therapeutics, so it's awesome. Someone we could ask, how common is presentation of varicocele in RCC, especially given left kidney here?
I'm going to say not super common, but we'll again let Sam take that one.
Yeah, I've definitely heard of the association, and knowing the anatomy is helpful around the testicular venous drainage and the renal circulation. So that is a possible presentation. Specifically, benign varicose veins are more common on the left testicle, whereas varicose veins on the right testicle are more concerning for a renal process or something systemic. But I've personally never seen it, but I confess I don't often look or do a testicular exam in someone who then is diagnosed with renal cell carcinoma. But the question is relevant for primary care and other settings where a varicose vein may be a presenting sign. So good to be aware of, but I don't have a good frequency. That might be available online somewhere to find, but it's certainly not something I've seen commonly in practice.
I also see another question from Shema. When it comes to, when do you suspect cystic renal lesions are sufficient for malignancy?
Yeah, so cysts, the kidney is one of those organs where you can very commonly see cysts. I think things that we often look for radiographically, and again, like the imaging, I think is key for, for really diagnosing what exactly is on the kidney. But we'll often see language around like simple cysts, which really just means it's a fluid-filled sac, versus, something that says like part solid, part cystic, kind of complex. That's something that might, I think, ping us to be a little bit more concerned that this is something that could turn into malignancy or could represent malignancy. And so sometimes it's a discussion with radiology, honestly, about what their index of suspicion. I think, as Sam mentioned, we rely on radiographic findings a lot, but certainly you can see simple cysts of the kidney, just benign. And then of course, part of, other conditions like polycystic kidney disease that, are not malignant and never will turn into malignancy.
Yeah, when you start looking at more and more scans, you will see commonly incidental renal cysts. And I'm not a radiologist, but even I can recognize now, having seen a bunch of them, these like totally circular, totally homogeneous dark spots on kidneys, both in the context of polycystic kidney disease and in the general population of people without any known syndrome. So those are, I would say, just pretty common. I don't have any numbers, but I've seen them quite a lot. And radiologists can very confidently call them, and we don't pursue them further for malignancy. But Meera's right on. If there's a solid component to the cyst, that's more concerning and needs workup.
Oh, just a quick curiosity. I actually have renal cysts bilaterally. And my teacher was like, no, don't worry. We're gonna see those cysts as a if it progresses or not through ultrasound. So I was like, okay. And just one last question, because we're running out of time. Does immunotherapy have a stage below which works best, or can be applied and expect to have fabulous outcomes for all stages of cancer?
Yeah, good question. I wish it had fabulous outcomes across all stages of cancer. I think that, that's constantly the goal we're working towards with all of our novel cancer therapies. But the short answer is that immunotherapy was first tested, as many kind of newer agents are. It was first tested in the metastatic setting for most types of cancers. And now actually it's being moved and tested in the early stage setting for a lot of types of cancers. So for example, in triple negative breast cancer, one type of immunotherapy, pembrolizumab, is now approved to be given in the neoadjuvant, which means before surgery setting for early stage breast cancer, because it's been shown to improve the response rates at the time of surgery. Similarly, another immunotherapy agent, atezolizumab, has been approved to be given after surgery for patients with early stage lung cancer, because it's been shown to prevent recurrence down the line. So immunotherapy is used most commonly in the stage 4 setting, but is increasingly being used in the early stage setting. Unfortunately, its outcomes do vary a lot by cancer type. So some of the ones I mentioned, melanoma, renal cell carcinoma, really those tumors can have like great dramatic responses to immunotherapy. Lung can have pretty good responses. There are other types of cancers where the responses may be more modest. And there are some types of cancers where there isn't a response yet, with our current immunotherapy agents. And so it's very variable. But again, the goal that we're working towards to try to get fabulous responses across all tumor types with our novel therapies.
Yeah, nothing to add to that. Great explanation.
I just want to, before finishing the session and giving the mic to Mukund, I just wanted to thank Sam and Meera. Such incredible educational session. I really loved it and learned tons, and I just can't thank you enough for spending your time, for teaching us. We're really thankful for that. Thank you. Mukund, the mic is always yours.
I think we were both just saying thanks for having us. It was fun.
Thank you. Please go ahead, Mukund.
Great. Thanks, everybody. I had all my teaching points served up to me on a platter. This was such a great discussion. I've attempted to summarize them as best as I can. I'll go over some of them now. We started with a discussion about red flag symptoms that you look for in a patient presenting with back pain. Notably, is it progressive? Does it have associated systemic symptoms, B symptoms, and so on and so forth? Or does it have associated neurosymptoms, in which case you should start considering your kind of misdiagnoses. We talked about how the spine is a common site of metastasis for a variety of cancers, including the prostate, the lung, the colon, and the breast. We talked about multiple myeloma as a non-solid tumor that is also frequently implicated in the spine. We talked about the differential between osteolytic and osteoblastic tumors, with osteolytic lesions most commonly being associated with myeloma and lung, and osteoblastic with prostate, although there's a caveat that these are mostly educational principles and that in real life, many of these may present as mixed. We talked about this person's prostate-specific antigen of 8.8 as greater than a threshold of 4 as concerning for prostate cancer, given this person's clinical presentation. But we also had a really interesting discussion about the value of PSA screening, especially in older men, given that prostate cancer is frequently indolent. Many people are found with prostate cancer at the time of death that isn't clinically significant, and the stressors and cost associated with follow-up screenings and imaging and biopsy may not necessarily be worth the improvement in outcomes for people of older age. When we got some information about these renal findings, this 4.4 centimeter mass on the left kidney, we started considering renal cell carcinoma as being on the differential, since it can metastasize to bone and the rate of metastasis is proportional to the size of the tumor. Although to my surprise, we learned that a 4.4 centimeter tumor is actually not that big for renal cell carcinoma. And also given the epidemiology of this patient, 77, that prostate cancer was still the most likely on our differential, but that renal cell carcinoma now has a spot there as well. Of course, it was ultimately renal cell carcinoma. And we launched here into a really great discussion about immunotherapy as a new method of treatment for RCC, as well as melanoma and some other cancers. Immunotherapy is super cool. The examples that I've included here, anti-PD-1 and anti-CTLA-4, are both signals that help with peripheral inactivation of T cells. And many tumors, including renal cell carcinoma, will express proteins that simulate the effects that these have on T cells and will essentially inactivate your own immune system. So renal cell carcinoma is effectively treated by agents that reactivate your immune system against that tumor suppression of your immune system. And the median survival is 5 years. And finally, we talked about how prostate cancer is frequently treated with androgen deprivation therapy and that treatment can be palliative with, again, a really great survival of between 4 and 5 years. Thanks, everybody.
Thank you, everyone. Thank you, Sam. Thank you, Meera. Again, it was such a pleasure. Hope everyone has a great week. Bye, everyone.
Bye. Thanks for having us.
Bye.